Good morning, everyone, and welcome to the Iowa Ideas Conference. In this morning's session, Access to Medicaid, the Future of Medicaid, and Who Will Be Covered. I'm Tom Barton. I'm the Gazette's Deputy Des Moines Bureau Chief, covering Iowa politics, including the Iowa legislature and campaigns. I'll be serving as your moderator, helping to guide today's discussion and conversation as part of Iowa Ideas, which seeks to explore the issues, address challenges, and share the big ideas that will shape the future of Iowa. I'd like to recognize our presenting sponsor, ITC Midwest, which helps make this virtual conference possible. So thank you to ITC Midwest. A reminder, audience members can submit questions to our panelists through the Q&A function. This session, is also being recorded and closed captioning access is available. So as I mentioned, good morning. Welcome to today's panel, Access to Medicaid. We'll be exploring how proposed Medicaid funding changes and work requirements could affect who is eligible, what it means for patients and communities, and what impacts we might see on public health in Iowa and beyond. Joining me today are Joe Locke, President and CEO of Eastern Iowa Health Center, which serves tens of thousands of patients across Linn County and beyond, many of them being Medicaid recipients. Welcome, Joe.
Thank you, Tom. Good morning.
Thank you. We also have Lee Grossman, Iowa's new Medicaid director, who previously led Wyoming's Medicaid program and now oversees one of Iowa's most critical health safety net programs. Welcome, Lee. Thank you for being here. And we have Cindy Feaster, Chronic Disease Services Coordinator at Linn County Public Health, who has deep experience in community health, coalition building, and addressing chronic disease management. Welcome, Cindy. Thank you for being here. So, as many of you know, Medicaid is more than just a government program. It's a lifeline for hundreds of thousands of Iowans, from children and families to seniors and people with disabilities. But new proposals to alter how Medicaid is funded, along with the addition of work requirements, could reshape who qualifies for coverage, how care is delivered, and what it means for communities that already face healthcare challenges. Again, we brought together a panel of experts with firsthand knowledge of Medicaid, healthcare delivery, and community needs. And so together we'll unpack what these policy shifts could mean in real terms for Iowans. So let's begin with some context. Joe, during our pre-panel discussion, you mentioned that nearly 7 in 10 of patients served by the health center rely on Medicaid, and that your center is seeing record demand for services. Could you paint a picture for us of who you serve and why Medicaid is so central to their access and care?
For sure, Tom. We're on the way this year to see 71,000 visits, the way we count one, at Eastern Iowa Health Centers when a provider sees a patient. And fully 7 out of 10 of our patients, of those 71,000 visits, 7 out of 10 patients rely on Medicaid for insurance. And overall, with regard to Medicaid in the state, more than 600,000 out of 3.2 million, so 20% of Iowans rely on Medicaid as well. And so one of the hardest things is that of the unduplicated patients, more than 4,400 fall somewhere on the spectrum of homelessness. Now, the federal government has a very broad definition of homelessness. There are not 4,400 plus people living in a tent or unhoused in Cedar Rapids. However, the definition is so broad that it includes people that are on a month-to-month lease, which are many of our patients. And so when work requirements become an issue, I'm really concerned that many of those patients will not be able to meet those work requirements and thus lose Medicaid.
All right. Lee, you've stepped into this role at a critical time, as we've mentioned, with changes on the horizon, both at the federal and state levels. Can you walk us through what's on the state table, especially around funding changes, new work requirements, and the timeline for implementation?
Yeah, of course. Thank you, Tom, and thank you for the opportunity to be here and visit with you all and Iowans tuning in. So welcome to the conversation. I'd like to first just level set a little bit, Tom, in terms of what Medicaid looks like in Iowa. You gave some good flavor when we first started off here. But to give us some scope, Iowa Medicaid covers over 700,000 Iowans statewide. budget of about $5.3 billion in terms of what we spent last year. So that's out of 1 every 4 to 1 every 5 Iowans, depending on where we're at for enrollment. And when we talk about who's covered by Iowa Medicaid, over half of our enrollment are kids. And then a lot of, like you mentioned, older Iowans, let's say getting care either to stay in their home or in a nursing facility, and also Iowans with significant disabilities. So we're a big player in terms of the state's insurance market as a payer and covering the most vulnerable neighbors in our state. So I think that's just helpful context before we get into some of the changes. And you're right, there's some really significant changes coming down the road that I'd like to talk about. And mostly these are from the federal perspective. So what's prompting these was the passage of the One Big Beautiful Bill Act, or HR1, however you might think of that bill. And it's going to happen not all at once, right? This is going to happen over the course of many years, really with everything coming into play in 2032. So we've got a long time, and we're still awaiting a lot of federal guidance and things that we just don't know, right, that we have to figure out. So what do we know today in terms of just the impact? You mentioned work requirements. So I want to start on the eligibility side of things. This is, I know, a very active conversation in Iowa, even before that federal legislation, but that requires that all states implement community engagement or work requirements by January 1st of 2027. And from a timeline perspective, Iowa's on track for that date. We're certainly working as quickly as possible, but that's really ultimately the date that we're working towards, and feel confident that we'll be able to hit. We'll of course communicate as that may evolve or change in the coming months here as well. But that's not the only item, right? There are also more frequent eligibility requirements, and that is these changes are both specific to what can be known as the Medicaid expansion population. And for those of you who don't live in the Medicaid world like those of us here, what that means is low-income adults who qualify for Iowa Medicaid. And this was a pathway that was created through the Affordable Care Act. And we have around about 180,000 Iowans who have qualified for Medicaid coverage through that pathway. So just to give a sense of that proportion of the total, about 700,000 enrollment that I mentioned earlier. So those will also, the more frequent eligibility requirements are applied to that group as well. And that's every 6 months, also in January of 2027. In addition, there's some really significant funding changes that, frankly, are very wonky, even for those of us in the Medicaid world. But at the end of the day, what that looks like are significant changes to the funding mechanisms on the federal side for how provider taxes are implemented and the caps on those taxes to draw down additional federal funding. That's about the simplest way I can try to describe that. And those are phased in starting in 2028, really. Starting into later in 2027, but really feeling the effect in 2028, and in a phased approach all the way through 2032. Ultimately, what that will mean is a decrease to the Medicaid program from federal, drawing those additional federal funds over the course of that time frame. So, Tom, that's, I know, trying to fit a lot of information into that question, but I hope that just gives us an initial starting point in terms of setting the stage and what we expect to come, again, really starting in 2027 and down the road, how that's going to affect us here in Iowa.
Yeah, I appreciate that. And as you mentioned, there has been a lot of discussion surrounding the community engagement or the work requirements. Can you talk about how compliance will be tracked and what safeguard exists for people who face temporary setbacks like illness or those who have caregiving responsibilities? Joe also mentioned concerns about the homeless population and those that don't have, I guess, stable housing.
Yeah. So and this is defined for us in federal law. So this isn't an Iowa specific definition, but there are a myriad of examples, exemptions where folks do not have to seek this, comply with this particular requirement. And for example, just to illustrate some of those, to the question that you had, that does include caretakers of children under the age of 6, someone who is pregnant and has a high-risk pregnancy, It also just in terms of age bands, under 19 or over 65, this would not apply. And then a host of sort of medical exemptions, including folks with disability, substance use disorder. So just to give you a flavor, and some of those are still, being walked through, but that's what's in federal law and obviously what we will work to implement here. So there's a host of those carve outs in terms of who this will apply to. And I think what the intent was of the law, far be it for me to interpret what Congress passed, but that's really the goal here in terms of the sort of quote unquote healthy or able bodied population and their ability to engage in their community work for a minimum of 80 hours a month. Now, the logistics of that is obviously something that's still being designed, and it's still a lot of the big administrative lift. But the guiding principle there is how we can do this in a way that is minimally burdensome to folks who are relying on Medicaid for their coverage. So leveraging any opportunities for technology in terms of being able to verify that through other state interfaces where we might already have some of that data. But that's really the goal, is how we can streamline this. And that does take time, right? It takes time and investment in the technology to have an efficient operation that can really minimize some of the back and forth passing of paperwork and those opportunities that can be a risk for folks and a burden on state resources as well. So that's our focus at the moment in terms of how we're working to implement this requirement.
Yeah. And state lawmakers earlier this year had passed a separate piece of legislation requiring work requirements for that Medicaid expansion population. What's the current state? How does that play into what we saw passed at the federal level? Does that essentially mean because of the federal bill passed, Iowa will now just go off of, those requirements instead of what was passed by the legislature?
Yeah, so as I think we all know from I'm sure our civics classes in Iowa schools, federal law does trump state law, but obviously that's a delicate dance, right? Where we're working to make sure that we're first complying with federal law, but also, for example, if the state has more stringent requirements, that we're implementing those as well. But really, it is a big logistical sprint right now in terms of how we can work to get that together to, again, operate in a way that's not going to result in any coverage loss for those who otherwise need it and should qualify, by meeting this requirement.
Yeah. Other states in the past have implemented work requirements for this Medicaid population, notably Arkansas and Georgia. What can we learn from how things worked in those states? What were some of the issues and challenges, and any idea how lessons from those states can be applied to moving forward as Iowa begins to implement some of these changes?
Yeah, so some of the comments that I mentioned in terms of how we can leverage technology is, I think, one of the big lessons learned from those states, and certainly from my conversations with those states. I think you see Arkansas in particular, who has had more experience in this area, trying to leverage some of those technologies. So, for example, with a state department on workforce services or workforce development that may have this data. For those involved in and engaged in the education system, how we might be able to interface and get information directly, so that way the applicant does not have to, again, provide manual verification. While a big lift is certainly a lesson learned there. And then communication, right? Just letting people know what's happening, when it's happening. So not only just sending out letters, right, as we certainly like to do in government, but how we can make sure that we're communicating in a clear and transparent way, so that way there's no surprises, right? I mean, that's my goal and my intent, so we can make sure folks are very aware that this is not a surprise of something that they have to comply with immediately in terms of, oh, it's this month that I'm learning about it. So that's a guiding principle here from my perspective, and we can do that through online methods, things like social media and some of those types of engagement, and then also just with partners like folks here today, right, in terms of how we can get the word out there. So that's our goal, Tom, and I appreciate you asking about how we can learn from other states, which is something that we certainly strive to do here.
Appreciate that. If funding gaps emerge, I guess, what do you see as the biggest risks for enrollees and providers? And I did want to throw in here and mention that the state auditor's office earlier this week pointed to the latest memo sent out by the state Medicaid forecasting group projecting Medicaid deficits reaching nearly, I think, 76 million and 181 million for fiscal years 26 and 27, respectively. I guess how is Iowa Medicaid planning on addressing those and addressing issues of cost containment?
Yeah, great question, Tom. And so today is my 1 month anniversary in this role, and I'm sure y'all can imagine, how challenging of an opportunity is to come in a resource constrained environment, like you just mentioned. So, to get right down to the chase, from my 14 plus years in Medicaid administration, there's really three ways, right? When you have significant shortfalls to make up that money, there's ways we can trim at the edges for administration and those types of efficiencies on the back end. And those are absolutely the things that we're immediately focused on. But administration usually accounts for 1, 2 to 2% of the total Medicaid spend, that total over $5 billion. So if we're talking in the millions of dollars, there's really three policy levers that the state has to pull. One is who Medicaid covers, right? Covered lives. The second is what we pay for those services, right? So how much, what those rates are, and then what services we cover. Those are really the three areas in my experience where you can get significant funding. So that is a intentional conversation, right? This is not a Lee Grossman gets to make those decisions. These are policy decisions with the governor, with the legislature, that need to be thoughtful and from my perspective, transparent. So those are the areas in which we're focused in terms of providing that analysis, recommendations, options based off of the data that we see, the facts that we see, and our expertise, obviously. So that's where we're headed. That's going to be the road, and certainly those are difficult conversations, right? In terms of those realities, but we have to face them head on. We've got to talk through those and do that together. Again, as policymakers in particular, for what the best course is for the state of Iowa and how Medicaid continues to advance our health policy goals in the state.
Yeah, I do want to move this conversation along and bring in some of the other panelists here, but I will throw one last question to you, Lee, from an audience member. They ask, can you confirm that a person who is unhoused and without a medical exemption will be subject to work requirements despite potentially not having access to stable housing, transportation, or consistent food sources?
Yeah, great question, and thanks for that. In terms of what's defined in federal law, I do not believe that unhoused is specific in there. There's some other categories in terms of good cause and things like that. So apologies, I don't have a direct answer to that question in terms of a definitive yes or no, but something where I think there's certainly more guidance and more policy that needs to be made in that area. So thank you to the audience member for that question.
Great. Thanks, Lee. Cindy, from a public health standpoint, what happens when coverage is lost or becomes harder to maintain? What ripple effects do you see on chronic disease management, emergency room usage, and community health overall?
Thank you for that question. This is a subject I love talking about. Health insurance and access to healthcare is certainly a passion of mine. So welcome. And welcome, Lee, to your first month. We're glad that you're here. So to address your question about the ripples in public health and what we may see should Medicaid be harder to maintain, we worry about interrupted PCP relationships or primary care provider relationships. So things that we've worked very, very hard messaging-wise with the public to make sure that people know how to sign up for health insurance, how to keep health insurance, how to use health insurance, how to get that PCP or primary care provider relationship established and going. We worry about that being interrupted. We worry about medication access being interrupted. missing follow-up appointments or the inaccessible nature of follow-up appointments, and then a rising risk of complications. So as you can imagine, if you show up to the pharmacy, and this is a typical situation when people have a disruption in Medicaid, when they call our office in a panic, it's generally due to the fact that they've shown up at a pharmacy counter or their doctor's office and they're told that their insurance is no longer in force. So that really causes kind of a bump in the road, I guess, with their access to healthcare. So we do worry about refilling of critical medications, diabetic emergencies, worsening heart failure, and overall it could lead to long-term worsening health outcomes. So those are kind of our worry points, I guess.
Yeah. Are there any specific, I guess, public health ripple effects that we should anticipate, like delayed care, worsening health disparities, or increased uncompensated care?
We do worry about those things, and we would forecast that happening if there are large numbers of individuals that would become uninsured. We don't know what that would look like per se, but we do anticipate that those things could happen. There could be an uptick in avoidable ED visits and hospitalizations as a result, and that can result in worsening of preventable conditions, bad debt to healthcare institutions and to patients alike. And we hope that we do not see that. We hope that we can work with the public to avoid that through messaging and preparation about what's to come.
Yeah. Joe, what pressures would cuts or work requirements place on providers like Eastern Iowa Health Center?
Well, for sure, one of the biggest things that that is forecasted to happen is that people that rely on Medicaid for insurance will have to enroll twice a year instead of once a year. And so currently we have 3 full-time employees that all day long, all they do is enroll people in Medicaid, which is a process that takes about 45 minutes. So, so one individual working full-time is able to help maybe 8 to 10 people a day, depending. And when, and here's an example. So under our clinic roofs last year, we had 46 languages spoken. And so there's some inherent complexities there. The first, of course, is English. The second is Swahili in our clinics. The second is Swahili. The third is Spanish. The fourth is African French, and then Haitian Creole and Kurundi and a whole bunch of other Pashto and a whole bunch of other languages as well. So, if you're not literate in your own language and you're not literate in English, and something comes in the mail, you may not understand what it is or if it's important or not. And I really appreciate Lee's comments earlier about utilizing technology to get the word out and help people understand, hey, this is coming, pay attention because you will need to re-enroll twice a year. When COVID hit and the public health emergency was declared by the federal government, people didn't have to enroll in Medicaid. And so for about 3 years. And so in other words, that was just a requirement that went away. And so once it was instituted last year, we had a big problem, and I'm sure it happened across the state, of just re-educating our patients and saying, hey, you still have to enroll in Medicaid in order to have benefits, especially for those that clearly qualify, income qualify. So just to give a little example of that, we have a little more than 70% of our patients. We talked about this a little bit earlier, but to put a fine point on it, 70% of our patients plus earn $31,250, which is the federal poverty level for a family of 4. And that's 70% plus of our patients. And so, if you're under-resourced socioeconomically as well as with regard to language and education and literacy and transportation, all of these things are going to play into this. And so we're just concerned about the overall health and well-being of taking care of our patients.
Yeah. Another question I had for you is, we've heard from Republican supporters of the reconciliation bill about work requirements and arguing that this will help strengthen Medicaid for those that it was truly designed to serve. I guess, how do you respond to that? And do you see that playing out? Do you see work requirements strengthening Iowa Medicaid for those vulnerable populations that Republicans say it was originally designed and intended to serve?
I think that I think the system will become more burdened. And when I say that, when I say the system, I mean what I'm really worried about is that if somebody loses their benefits and or is unable to complete the work requirements and loses their benefits, and they have a headache, they could show up at the emergency room, at the emergency department, to which they may end up getting a Tylenol 3, and that's uncompensated care for the hospital, especially if they require if they dial 911 and require an ambulance ride and to get there and back, and then the emergency room visit, and then home. I mean, that's just going to be uncompensated care. So I'm worried about the hospitals, and not just the hospitals that are large, but also the rural critical access hospitals, and being able to keep their doors open. In a way, federally qualified health centers like Eastern Iowa Health Center are like an emergency department diversion program. You know what I mean? So because we are able to operate in a very efficient manner, and so the cost of care at a federally qualified health center is literally 72 cents on the dollar for what it is in private practice. And so in that case, and speaking of, the Democrats in general love us because we don't turn anybody away. In other words, if you don't have an ability to pay, we treat you anyway. We write grants. We really work hard to make sure that we can provide access to anyone, regardless of their ability to pay, and that is something that is really unique to community health centers, federally qualified health centers. So that is something that we're just going to be acutely aware of. Now, when I said the Republicans or the Democrats love us because we don't turn away anyone, the Republicans love us because we are able to operate at 72 cents on the dollar. And so, we have broad bipartisan support. However, that Medicaid expansion population, so those between 133 and 138% of the federal poverty level that Lee talked about earlier, those are the ones that we're really worried about.
Yeah. Cindy, I saw you nodding your head. Did you want to jump in here about, the larger pressures that this would have on, I guess, the healthcare sector in general?
I agree with a lot of everything Joe says. So there's a lot of head nodding, but we just want to make sure that we don't undo a lot of the progress that has been made within the last 10 years. So rolling out access to healthcare for working low-income adults who were previously shut out of getting health insurance, sometimes even no matter how much money they were willing to pay. There are just some provisions in the Affordable Care Act that have made healthcare access available, and Medicaid is one incredibly beneficial tool in this insurance tool chest, and we just want to make sure that we don't do something that's going to undo a lot of the work that we've been putting into place to make sure that that our friends and our neighbors can have health insurance and access to health care. And we don't want to make it any harder to navigate, any more complicated than it is right now. It is very confusing. Public health regularly interfaces with the community, doing community health improvement plan work and focus groups and all those things. And people tell us that literally, this is a quote recently, health insurance is the most confusing thing ever, end quote. So we don't want to complicate this any further. So
Yeah, so to that, and to something that Joe brought up earlier, and this is a question from an audience member, they ask what steps will be taken to ensure that the educational pieces and renewal information will be sent to families in their home languages to help eliminate those barriers. Is that anything, Cindy, you can talk to? And Lee, I'll throw this to you as well.
Yeah, I think all of us could probably answer this, but just really quickly, I looked on Iowa HHS's website and they have a really good one-pager that has bulleted information, and it very clearly states who these proposed work requirements do not apply to. There are pictures, like infographics in it, so it is digestible. And then our hope as like a community provider here in public health is when we pull all of our partners together to work on our community health improvement plan and goals, one of which is access to health care, that we can take this information and ensure that it is understandable and in the hands of individuals who need it. So I'll let everybody else speak, but boots on the ground, that's what we plan to do. We don't do that alone. We do that with hundreds of partner agencies. So.
And Cindy, if I can just add on to that, thanks for plugging the website. We did not plan that in advance. hhs.iowa.gov. Lots of great information out there. Really, I mean, truly phenomenal resource. One, to make sure that information is accessible into language that folks on Medicaid will need, but also I want to emphasize, and something we'll continue to do, but want to emphasize those partnerships, right? In terms of you all know those populations and can help us, because it really does take those types of partnerships to make sure not only that it's accessible in the language folks need, but also that we're getting it to them at some of those access points as well.
So Medicaid in Iowa has gone through big changes before, privatization of management, waiver redesigns, and more. I guess, Lee, my question to you is, I guess, what lessons have been learned from those transitions that might help Iowa prepare for kind of this next wave of changes?
Yeah, great question, Tom, and I could talk about that one. I think all day. I mean, in the public sector and certainly in Medicaid, this is a prime example where change is constant, right? You cited some of the significant ones. We've talked about some of those upcoming, and there's more that's not on our radar, right? That I'm sure both at the state legislative level, the federal level, those things will continue to evolve, and we have to learn from those, right? So from my perspective, you mentioned the transition to managed care, huge change to the system. I think from my conversations with healthcare providers in particular, but also other advocacy groups to date, the healthcare system has certainly adjusted over the course of the last nearly decade in terms of what that looks like. And so we're in a different place now than we were when that was first rolled out. You mentioned the way in which Iowa serves people with disabilities, especially trying to keep them in their home, in their community where they want to be. There have been changes, and that's a conversation I'm very excited about looking forward in terms of what those will continue to look like. This is an area where I've had a lot of experience and passion, and where Medicaid has learned from folks in terms of service recipients, engaging with communities directly through town hall kinds of conversations, that services for people with disabilities can be confusing to access. That seems to be a recurring theme here in terms of just getting connected can be very confusing. That services needed to be more tailored to the individual's needs. And that also, frankly, the state needs to be evaluating those lessons learned, right? To the spirit of your question, as I understand it there, Tom. So this is all through an initiative that we are doing to redesign how those, what we call Medicaid waiver services, these again are home and community-based services for people with disabilities, and how those look like. And so just real quickly, one is just that access point, making sure that people can access these services, and that we're focused on that being from application to services starting as efficient as possible, and that we are focused in tracking our progress through waitlist times. These are very expensive services that people rely on typically for their lifetime, or at least on a long-term basis. And so there is a significant waitlist of funding. Just to give you some numbers, 27,000 Iowans currently receive these services, yet we have a wait list of about 23,000, right? So you can see that significant demand that is there. And we want to balance and make sure that we have services that are responsive to not just the diagnosis someone has, right, of autism or Down syndrome, but that through the planning process, people are taken into a full picture in terms of what their needs are, what their goals are for themselves. So that way we're serving that whole person and designing services around that whole person rather than putting them in a diagnosis box. So those are the significant changes and where we've been able to learn from our communities that we work with, that we partner with, for how we'll move the needle moving forward, not just for those 27,000 Iowans who will rely and continue to rely on these services, but for those 23,000 Iowans who are on the wait list. And we want to make sure that they get connected to services as efficiently and effectively as possible as well.
Yeah. So as part of that process, I guess, how will you ensure that rural Iowans and those with the most complex needs, I guess, don't see gaps or disruptions?
Yeah, so serving, especially focusing here on how we serve people with disabilities, the rural community is our key part of that. I myself grew up in rural Iowa, from Southwest rural Iowa. Shout out Shenandoah for anybody who's listening on the opposite side of the state there. But really, one, we look at provider network, right? We need to know that there are providers and folks to serve these individuals statewide. I think that is critically important and one of the first things that I look at in particular in terms of, do we have an adequate statewide network for folks to be served wherever they want to live? And supporting people in those communities, I think, is a critical policy goal, and also just good program administration. In addition, that goes back to the planning process. And that is something that we at the state get feedback directly from participants. So not only the quantitative part of the equation of, do we have adequate provider networks? Are people, in terms of just our overall service recipients in those communities, but also understanding qualitatively from those folks, are you getting the services that you want? Are you happy with your service providers, right? Are they meeting your needs? And we have, of course, so this is sort of aggregate survey feedback, but that's really important to us too, right? In terms of, are the service quality in those rural areas and statewide meeting the test of what those people need? So those are just a couple of the ways, Tom, in terms of how we're going about that. But again, that's where the continuous sort of feedback loop, engaging with folks, having robust data dashboards, which are publicly available on that website we've been plugging, where people can also review that and continue to let us know how we're doing and hold us accountable.
Yeah. So speaking about data and feedback, are there specific metrics you plan to use to determine whether the redesign is improving outcomes and protecting vulnerable populations?
So I think number one, just a real fundamental baseline net measurement in this area is the percentage of Iowans who are getting care in a institutional type of setting. So think nursing facility, those types of setting, versus those who are getting services through home and community-based services. Typically, what we find is not only are those services more cost effective, but oftentimes that's where people prefer to be receiving services. That's a very individualized choice, of course, but that each individual gets to make for themselves. But that's something that typically people want to support, right? For ourselves, our loved one. So number one, that's a real baseline metric of, are we seeing more services or the same amount of services in the community? I'll also just hammer on the provider network ability. So for example, what those ratios look like, for example, of case managers and how many individuals that they're serving. So what that maximum threshold looks like, because that's a way we can tell the time that people are getting with those types of providers, and that we don't have hopefully overwhelmed providers, right? So people are getting that individualized attention.
Right.
So that's, I hope, just a quick snapshot, but definitely something that we'll continue to make publicly available too.
Great, appreciate that. And just quickly, another question we have from an audience member. They're wondering, is there any discussion about returning Iowa Medicaid to a state-run rather than a contracted service?
Yeah, so just to perhaps translate some of that question as well. You referenced, Tom, in a question a little while ago, the transition to managed care, which is where there is a private entity that the state, or entities in our case, where the state contracts with for the functions like paying claims, enrolling providers, and those types of things. So state Medicaid agencies have made different decisions. Like you mentioned, I came from Wyoming where it was state operated, right? So I've been able to learn and see the breadth of how states administer this. That is a high level policy decision, certainly beyond us here at Medicaid is I think the most concise answer. Transitioning, as I think the state experienced initially, is highly disruptive to a healthcare system, whether you go from one arrangement to the other. And frankly, can also be very expensive too. So those are the types of, and frankly, that's analysis that I don't have and I'm not aware of at this point. So not under active consideration, but it's something that, the state needs to be very thoughtful in terms of what are our health policy goals, how we operate as a Medicaid system, how can we best serve providers, and ultimately at the end of the day, make sure that Medicaid members are getting the services and supports that they need.
Yeah.
So thanks for that question.
Yeah, appreciate that. Looking forward, let's turn towards solutions. So, as work requirements and funding changes move forward, what strategies could cushion the impact on vulnerable populations, and what policy reforms or collaborations would you like to see prioritized? Joe, maybe I'll start this conversation off with you. I guess, how would you answer that question?
Well, one thing that we are confident about, excuse me, is that the very robust Hawkeye program, the Medicaid for children, will continue. And so, one of the ways that we are, and just to kind of paint a quick picture, so a decade ago, we provided primary care and a little bit of prenatal. Today, we provide family medicine, pediatrics, OBGYN, dental, behavioral health, pharmacy, medication-assisted treatment for those with substance abuse disorders, and then we just opened a pharmacy. We're going to start a walk-in clinic in a couple of months, and in the first quarter of 2026, we're going to start vision care as well. And so one of the ways that we are preparing for what we expect to be very significant challenges to certain parts of the Medicaid population is to cater our services. In other words, to basically engage in risk stratification from the standpoint of adding services. And so, as I mentioned at the beginning of this, that we're on the track to see 71,000 patient visits this year. I expect in 2 years we'll eclipse 100,000 patient visits. And so, one of those things is expanding pediatrics, expanding behavioral health, expanding telehealth. In other words, when I say expanding, I'm saying we already do those things, but adding providers. And so, as Lee and maybe Cindy alluded to, was making sure that people have access to that primary care provider, that PCP, or whatever that patient needs, which may be a pediatrician, it may be maybe multiple things. As a whole, the 14 federally qualified health centers in Iowa, which, by the way, there are also 14 in Hawaii, so it's loosely population based. There are about 1,500 federally qualified health centers in all 50 states, plus Puerto Rico and Guam. And currently, we serve 1 in 10 Iowans as a network, and across the nation, we serve 1 in 10 Americans. So literally 35 million people utilize a community health center for their care. And the other thing that's common to all of us in our particular space is that it is very common for us to. Here's a couple of examples. One is that it's not uncommon at all for our patients to have 7, 8, 10 chronic conditions. And so, a lot of times that our patients are sicker, and because they're really trying to face the crisis du jour. I mean, is it food insecurity, clothing insecurity, housing insecurity, transportation insecurity, or all of the above? And as Cindy alluded to earlier, do we go buy diapers today, or do we pay for our prescription, or we try to put food on the table? So, and another example is that we are grateful in Cedar Rapids to have 2 free clinics, and free clinics have an important role in all of this. But they are very transactional. In other words, you go in and because you are hurting, you have a sore throat, you have the flu, and they take care of you, and no money changes hands. However, what happens all day long here in Cedar Rapids, for example, is that as that person comes in to get that prescription for a sore throat at the free clinic, they'll say, well, you also are suffering from obesity and diabetes and COPD and hypertension. You need a medical home. So it's so free clinics are terrific, but they're very transactional, which is what they're designed to be. What we are here to do is provide a medical home, and that so we get calls all day long from the free clinic saying, "Hey, this person really needs to be seen for multiple chronic conditions." And so, we talk about expanding services, even though 10 years ago we saw 8,000 visits, patient visits. This year we'll see, as I said, we're on the way to 71,000. And we are currently serving 32.5% of the eligible Medicaid population. In other words, we could grow. So back then, I started here almost 11 years ago with 18 employees. Now I have 135 or so. We'll have 150 by the end of the first quarter of next year. And yet we could be literally 300% larger and are serving 300% more people before we actually achieve market saturation in Lynn County and surrounding counties. So the need is tremendous.
Yeah. Lee, during our pre-panel discussion, you talked about the Rural Health Transformation Program, the $50 billion fund included in that reconciliation bill, or HR 1. How might that funding be leveraged to protect access in rural Iowa?
Yeah, thanks for bringing that up, Tom. And we've been talking a lot today about how resources are, we expect those to be constrained. This is an area where there's additional opportunity. So you mentioned what that looks like at the national level. What it looks like for Iowa is a minimum of $100 million per year for the next 5 years. And we expect it to be significantly more than that $100 million, but that's based off of a competitive grant process at the federal government. And so we're in the process right now of having engaged with stakeholders and are finalizing that application that's due next month. So what's it going to do for rural Iowa? It's really focused on impacting a few key areas that we have identified, again, with stakeholders, and also are mirrored in this federal opportunity. And this looks like focusing on chronic disease prevention. So think of some of the biggest issues that we have with chronic disease in Iowa, and especially rural Iowa. I think most folks here know we have very high cancer rates, for example. So how we can help with developing some regional centers of excellence, for example, with partners across the state. Also EMS sustainability and access. I think that anybody in rural Iowa knows that can be a very significant challenge. At the end of the day, I think people in Iowa, regardless of where you're at, expect if you dial 911 for someone to show up, right? And for someone to answer your call. So how we can support EMS access in those rural areas, I think, is a huge opportunity for this funding. And then also, lastly, just how we leverage technology to maybe think of doing services a little bit differently and really be able to extend the staff, the medical personnel that we already have in rural areas and help bridge some of those distance gaps that are just a part of living in rural Iowa, right? It's a great part, but it also can be the challenge when you're trying to be connected with healthcare, especially specialty types of healthcare. So that's an exciting opportunity where we're very active in that space right now.
So for those watching or listening who might not be familiar with the Centers of Excellence, can you just briefly kind of describe what those are, kind of how those operate, how they're structured?
Yeah, so just conceptually, let's say you have a regional hub, right, like a larger hospital that will enter into agreements with other partners in rural areas or communities to help deliver that more focused or specialized care that, frankly, the volume just may not exist in a smaller community. So again, trying to bridge some of those distances to get some of the best care that the state has and that we can offer here in Iowa to some of those more rural communities. So thanks for Tom, and I hope we're not inundating folks with too much healthcare administrative jargon today.
Yeah, I know. I appreciate it. Thank you for clarifying that. Cindy, what role can public health agencies, nonprofits, and community coalitions play in ensuring Iowans maintain access to essential care?
Yeah, I thought you'd never ask. So this is a subject that I'm really passionate about. So we believe strongly that everybody deserves access to healthcare, and in doing so, we work very hard to be inclusive of all community partner agencies and function kind of like Switzerland, if you will, to help be that integrator organization where all of our partners, even if they compete for same patient populations or whatever, can come and work together for the betterment of community and public health overall. And going back to that last segment where we talked about a past policy shift, during the time frame when Iowa's Medicaid system went from being state-run to being with the managed care organizations, we had the very unique opportunity to enter into a state innovation model grant period with Iowa HHS and other partners. And during that time, we were able to develop a community care coordination concept and deploy technology that is a very low barrier for all, I guess, community agencies to engage in the use of, to ensure that we are addressing all of the social determinants of health that people face, one of which is access to health care, getting and keeping health insurance. And so we were able to pilot a process and refine it. And now we have technology in place that is one of the solutions and a very, very good opportunity for the entire state of Iowa to replicate what's going on, to make sure that our health agencies, community partners, coalitions, nonprofits, you name it, can work together to ensure people have access to health care. Only one tool in that toolbox is Medicaid, but we want to make sure people know where to turn to get that coverage in place and to keep it in place. And those same agencies can help spread information that is factual and get people to understand how and when to take action. We work very hard to dispel misinformation that's out there around healthcare changes, if you will. We work really hard to simplify enrollments and renewals. We work with the systems and the processes that are in place, but we work very hard to be that bridge between the system that might be a little bit hard to understand and the community, which needs our help. We also work hard to plan for the what ifs and try to make sure that like bridge support is in place if we need to do something different and pivot quickly. We work really hard to strengthen the safety nets that are in place. And as public health practitioners, we're kind of in a unique space where we can deploy people like epidemiologists to help us track maybe some of the early indicators of some change that we need to address, right? So we just work really hard to try to bridge all these things and be this place in which we can innovate, work together, and help our population be as healthy as possible. So,
yeah, thank you. We only have a few minutes left, and I don't want to dwell too much on this since we've already talked about it, but we've got another reader question and kind of just speaks to, again, the level of kind of interest in questions around the reconciliation bill and specifically the community engagement piece, the work requirements. But Lee, just quickly, I'll go to you one last time on this. The question from the audience member is, what kind of budget does or will HHS have or need to implement the new law? And I think more broadly, the question gets at, how well positioned or prepared, is the state to implement some of these new changes? And so I'll just throw that to you.
Yeah, thanks, Tom. And just real briefly, don't have a specific budget number in terms of an ask. I know that's under development through the appropriations process, and there's obviously a conversation with the legislature. But just generally speaking, there obviously is our resources needed to make that happen, right? From a staffing perspective, doing eligibility determinations more frequently and having additional information that we're verifying. That doesn't just happen in people's spare time, right? So there's an administrative and a technology component in particular that will go into that implementation, especially again over the next year in particular.
Right. And looking ahead as we kind of wrap up this conversation, Lee, I'm curious, what gives you the most optimism and what keeps you up at night about Iowa Medicaid's future?
Yeah, well, great, thoughtful question for us to wrap up with. It's the similar answer for both, and I'll explain why. When I think about, where Iowa's population is, obviously we have our urban areas with a lot of healthcare resources, but still access can be a challenge. What really keeps me up at night is the focus on our rural areas. We all know rural Iowa is aging. Just about 50% of Iowa's senior population lives in rural areas. And so making sure that we have vibrant communities, vibrant rural communities where people can get the healthcare access that they need throughout their lifespan, right? From when they're kids, starting a family, and as folks age, that people can form those healthcare relationships and stay where they want to, right? And not have to pick up and move towns just because of healthcare access. So that's one of the things that keeps me up at night, and how the state, and specifically Medicaid, can partner with public health entities, providers, and all stakeholders involved to emphasize the vitality of those rural communities. But what gives me the optimism is, as I alluded to, having grown up in rural Iowa, that's how my family that gets access to healthcare services. Seeing those relationships and the true time and care that healthcare professionals provide, I know across the state, but just from that experience in rural Iowa, is really encouraging and something that we can build off of, and that is a cultural thing, right? I think we all know that as Iowans, the importance of those relationships and how we can continue to leverage those at the very individual patient clinician level interaction to help inform some of our broad, really big picture healthcare challenges that we deal with. So building off of that quality of care, those interactions that you just cannot replicate overnight, is something that gives me a great deal of optimism for just how we are and how we treat each other.
As I mentioned, we only have a couple of minutes left, but really quickly, for Joe and Cindy, I'd like each of you to leave the audience with one particular takeaway. What can providers, advocates, or even everyday Iowans do to strengthen Medicaid and access to care in their communities? Joe, I'll throw it to you.
Well, first of all, Lee talked about being partners and active partners. We rely on Medicaid, Iowa Medicaid Enterprise at the state, local hospitals, public health, to really, we're all in this together. And we look at these entities as part, hospitals, obviously. We look at all of these all of these entities as partners in working toward the common good. And with regard to, you use the word advocate, let your voice be heard at the, with state legislators. I just got back last week for my 4th trip to DC this year to lobby our people, our Congress, our senators and representatives. And it's important. It's important that they hear from Iowans, in DC and at the State House. So, it's a partnership and also be an advocate.
Great. Cindy, we've got about 30 seconds to a minute. Really quickly,
Yeah.
your response.
So we invite the public to join in this effort, just like Joe said, but come join your local public health coalitions, help people get and stay connected to care, avoid crises, help people not fall through the cracks. We as Iowans can co-create solutions to anything that comes our way, but we can also be our own best advocates. So come join us, help us ensure that there's help available through community health workers, data sharing, navigation, and outreach. We need the public's help to make sure that we are making this the best place to live, work, and play, and people have access to healthcare.
All right, great. Well, I want to thank our panelists, Joe Locke, Lee Grossman, Cindy Feaster. Thank you so much for your insights, for your participation, for participating in this discussion. Thank you to our audience for your questions and your interest. And thank you again to our sponsor, ITC Midwest. Up next in our healthcare policy track at 10:40 is challenges with healthcare staffing in Iowa. The Iowa legislature and Governor Kim Reynolds have attempted to address the shortage of physicians with proposals that would consolidate student loan repayment programs, leverage federal funding to create new residency spots, and prioritize Iowa students for medical school admission. How can you continue to attract people into all healthcare roles, and what can we do to increase wages among some of the medical support staff? That'll be tackled in the next discussion. And then at 8:30 a.m. tomorrow, don't miss Heather Gudenkauf, an Edgar Award nominee and New York Times and USA Today best-selling author. Her books have earned critical acclaim, sold more than 2.5 million copies, and have been translated into over 25 languages. They've also been highlighted on the Best of Us lists from outlets like the New York Times, the Washington Post, and NPR. So she'll be given that keynote tomorrow morning. Don't miss that. I'm Tom Barton. Thanks, everyone, for attending. Appreciate your time.